Thanks so much for letting me come have some time here just to talk to you about our study. So I'll just get right into it. All the presenters today have sort of really highlighted, the pandemic that we're studying and described it very succinctly. So I won't go into too much detail, but it's just to say that it's well understood that the outbreak has pressurized healthcare systems across the world. And we have tried to adapt by recruiting additional healthcare workers, building new facilities, and mass producing necessary medical equipment. But ultimately, we've had to manage this growing competing demand on our healthcare service, and ultimately to reduce overall mortality for our patients and our healthcare workers. It is also well accepted that the highest mortality rates have been in people over the age of 60 and those who are immunocompromised or have underlying health conditions. And our healthcare professionals are at the forefront of that, providing treatment and diagnostic tests for patients suspected with COVID-19. And what we do know now is that our patients with kidney disease, and particularly those that are receiving renal replacement therapies, are at an increased risk of severe experience of the COVID-19 virus, and they're advised to take extra precautions to reduce the risk of exposure to the virus. And therefore, working in nephrology units during the pandemic and managing these patients carries additional unique burdens. So there is growing evidence that has been well established that a high incident rate of acute kidney injury is considered to be a complication of the COVID-19 infection in hospitalized patients, with up to 30% requiring hemodialysis support in the ICU setting. So the pandemic and the related acute kidney injuries has increased the demand on kidney services, leading to concerns about shortages of equipment, dialysis equipment, renal healthcare practitioners, and the potential need to ration treatment within the UK. And when we looked at sort of the evidence that was there for nephrology healthcare professionals, to date, much focus has been on medical personnel working in intensive care, emergency medicine, and oncology, and very much limited attention to nephrology. So acknowledging that there are significant stressors heavily impacting on these staff, there should be an urgent priority on health and well-being in our renal healthcare practitioners to ultimately to avoid burnout and allow them to sustain their ability to engage in effective clinical work. So we felt there was an urgent need to carry out almost a snapshot of what was going on in nephrology. And the aim of our study was to explore the impact of COVID-19 on renal healthcare practitioners in multiple countries using an online survey. And ultimately, this was just a snapshot, but we did subsequently conduct semi-structured interviews, which I'm not going to report today. So the online survey was conducted with our healthcare professionals, and they were recruited in collaboration with the European Dialysis and Transplant Nurses Association. And this was also shared with international renal healthcare practitioners networks. We collected demographic information and provided a self-designed survey, which largely focused on COVID experiences, both binary and open text questions, from assessing ratings of PPE access, number of COVID tests, number of periods of isolation, level of new practice understanding, and ultimately we also included standardized questionnaires. And this included the general health questionnaire, which measures mental health distress, which provides a severity level and a prevalence level. And we also looked at the Maltby's Burnout Inventory, which is a measure of burnout. And this provides 3 scores across 3 dimensions: emotional exhaustion, depersonalization, and personal accomplishment, which is reverse scored. And so initially today, I'm just going to show you the descriptive statistics. So in total, we had 251 healthcare professionals from 28 countries. Almost a third was made up by Australian respondents, and the next cohort was from the UK, which is around 66. The majority were female. They were nurses. They had average years experience since qualification of 21.5 years, and working in renal disease, it was approximately 16.3 years in renal healthcare. The survey responses indicate a level of satisfaction in relation to preparedness, training, and access to personal protective equipment. However, one of the standout results we took from it was that 40% experienced fear in attending work. Just under a third, when we looked at our burnout, under a third of our respondents experienced burnout across at least one domain, and that was emotional exhaustion. That had the highest prevalence compared to the 2 other domains. Emotional exhaustion is considered to be the most commonly used domain as a proxy for burnout. And of the 3 burnout dimensions, exhaustion is also closest to a typical stress variable and therefore thought to be more predictive of stress-related health outcomes than the other 2 dimensions. And we find that a similar study conducted at the same time with ICU healthcare professionals reported similar prevalence of emotional exhaustion. So that suggests our renal personnel are really experiencing unprecedented demands in a workload intensity as seen in ICU. So in relation to the other 2 dimensions, it was difficult to compare it to other studies. Other studies report a variation in burnout. Pre-COVID, there wasn't anything there during the same period that we were testing. And when we look pre-COVID, we find that there is variation in the outcomes for these dimensions and how they're used. So the variability can be down to the inclusion of different professions. So nurses working in hemodialysis units tend to report moderate burnout compared to medical physicians who report higher prevalence of burnout. It's also important to acknowledge the diagnostic criteria for clinical burnout is a growing area within the literature, but there continues to be no consensus in the definition. Again, another problem with diagnostic criteria is a recent review was done and found that actually this test can be used and scored 58 unique different ways. So it really demonstrates that what's out there at the minute may not be consistent or comparable. And just as well, there is argument that actually depression is actually a better surrogate or a marker of depression or of burnout. And there's growing sort of research in that area. Various international studies have clearly demonstrated that depression is highly prevalent in our healthcare workforce during the pandemic. And then just with our other standardized measure we used, it was looking at mental distress. And we looked at severity and prevalence. So we found that a score of 14, a mean score of 14 out of 36. And also we found that that was higher than the general population tested during the same period. When we looked at prevalence, we found that 49.8% of our renal healthcare practitioners also experienced mental health distress. And this was higher than compared to the same period of emergency medicine, intensive care, or those working in those similar areas during the peak of the COVID-19 pandemic. So that was quite interesting in that we can compare that directly with other specialties. We also acknowledge that it is important to do long-term assessment of mental health distress. The timing of psychological assessments and the importance of follow-up is very important. We've read reviews that have shown that in previous pandemics and in the current pandemic, that psychological distress can continue up to 3 years in approximately 10 to 40% of studies. So ultimately, we're highlighting that there are flaws in how we compare our assessments. But I think ultimately what we found was that emotional exhaustion and mental health distress were prevalent in our sample of renal healthcare practitioners, mostly made up by nurses. And as the pandemic has continued, it is important to consider the long-term impact on how already a stretched workforce is dealing with this and possibly at risk of developing mental health disorders. This cross-sectional study is, as I've said, a snapshot of distress, but further studies should consider longitudinal study to capture this distress over time, particularly within individual groups and professions. And we are underway with our qualitative analysis. And Luigi, you really highlighted various things that we've seen come up in our qualitative work, but future research and hopefully future interventions are required to understand and improve the provision of psychological support for specialist medical and nursing personnel.